including Asian Hospital and Medical Center, the Medical City South Luzon, and Healthway Cancer Care Hospital. He also serves as the president of the Philippine Society of Vascular and Interventional Radiology. A proud BALIC scientist awardee and a clinical fellow trained at the Massachusetts General Hospital under Harvard Medical School. He has brought back global expertise to local practice, making innovative, minimally invasive treatments more accessible to Filipino patients. With numerous publications, teaching engagements, and leadership roles both locally and internationally, he continues to inspire the next generation of medical professionals while staying grounded in the service. Please join me in welcoming Dr. Cicero Matthew Abito.
Hi, good afternoon po. So, it's my pleasure to be here. Thank you for the invitation. Sorry, we had to change computers kasi to connect. For those who are meeting me for the first time, my nickname is Roy. I'm an interventional radiologist. And I hope you forgive me, for the intro. I always start my talks with a couple of slides about what an interventional radiologist is. Kasi even among doctors, that's one of the downsides of my specialty. People don't know what an interventional radiologist is. Nako-confuse nga kami minsan with radiation oncology. So minsan yung referrals na madating sa amin for RT and vice versa for sa radiation oncology. Dali. Okay. So, in a nutshell, vascular interventional radiology encompasses both oncologic and non-oncologic work. Obviously, today we'll be talking about specifically HCC work, but this is just a smattering of what we do. For oncology, aside from the local regional treatments, we do biopsies a lot. There's a lot of tube placements for palliation, of course, in the later stages. And we also do nerve blocks for pain. So, interventional radiology is a fellowship after residency in diagnostic radiology. You have to learn how to read your images first so that you can do image-guided procedures. So I'll go straight to biopsy because there's a lot of slides and I'd like to maximize the time. When we do biopsies, it's usually, in the context of liver cancer at least, when we do biopsies, the goal is to get a sample without seeding. That's always a question. Nag-biopsy, Doc, baka pag nag-biopsy, magalit yung tumor. That's the layman's term. No? That's what patients sometimes ask. And even from colleagues, the concern is, pag binayopsy, baka kumalat. The answer is there's a way to do a biopsy which is relatively safe, and that way takes a lot of image guidance. If you look at the image on the right, you see a needle that goes through the liver parenchyma. This is a liver ultrasound, it's ultrasound-guided biopsy. And you intentionally cross the normal tissue first before hitting the lesion. I don't know if you can appreciate it on the screen, but on the left, there's a red arrow pointing to that darker area. That's the tumor or the nodule. And you see a needle here that intentionally, instead of going straight, because if you notice, you could easily puncture straight from here. Mas maikli nga eh, diba? It's a shorter route. You could argue it's a faster biopsy. But it's also more prone to seeding because if you start bleeding here, if you can see I'm sorry, you can't see the cursor arrow pala. But if you bleed around that area of that red arrow, then you start seeding potentially into the peritoneum. That will not happen with this approach in the middle because there's effectively a tamponade from that needle against any seeding and bleeding into that tract. And additionally, although you don't see it on the images, what we do is we replace a stylet into the access cannula before we take it out so that you don't drip cells figuratively into the tract. So that's just a quick intro about biopsies. We're here to talk about local regional treatments rather than the biopsies, but we have to talk about histology if you want to talk about local regional treatment. And the reason is not all tumors will respond the same to your local regional treatment. And that's part of the job of the interventional radiologist, of course, during the MDT, is to figure out, will this patient, based on the imaging and the available histology, if you have a biopsy, will this patient respond well, or will this patient need what is known now as combination treatments. No? So most of us know this, but this is just again an overview slide to show you that they're not all liver cancers, not all HECs are the same. No? Way back in the world of oncology, we used to describe cancer as a one size fits all. Pag may cancer ka, you get chemo, and it's all the same regimen. And also way back, we used to call HCC the same. If it's HCC, you have a high AFP, then the treatment is the same. Nowadays, we've shifted away from that model. And when you do have the benefit of a biopsy, which, by the way, always should be a core biopsy, then you can go into this sub-categorization, which helps you well when you start to plan the treatment. So to cut to the chase, now you can see that there are worse prognosis tumors at the bottom. I won't go into them one by one. These are also among the tumors with the worst prognosis. But the bottom line is, if you're going for treatment, if you have a well-differentiated and a conventional type HEC, which thankfully is the more common type, you have a better chance of responding very well to local regional treatment. Now, saying this doesn't mean that there's no hope if it's not this type of biology or histology. But what I'm driving at is that if you have a different kind of histology, you want to employ different tricks also to supplement. And that's where a combination of radiation and medical oncology treatments comes in. Oops, sorry. So this slide, sorry, was misplaced, but it just shows you that nowadays we do large core biopsies. Gone are the days where FNA was enough and you just need to know whether it's cancer or not, and a small shaving of cells is enough. And this is what happens. You know, with the old traditional FNA, it's like asking a pathologist to interpret the artist of a painting by giving one piece like this. In fact, we have specialists in pathology where they're called cytopathologists. That's really what they train in. It's like naming a song with one note. Basically, it's a pathology. But it's very hard. No? And a small minority of pathologists are trained in this. So on a larger scale, you can't expect them to do a diagnosis with just an FNA. And aside from that, all our oncologists will know that you cannot do your immunostaining or immunohistochemistry if you only have an FNA. So that's why nowadays, the standard is really doing core biopsies. So let's go now finally to the main topic for which I was invited, which is loco-regional therapy. Now, I just show this slide to impress on everyone that there's no real answer. No? There's no single answer. What should be done? There's no cookie-cutter approach here. When you have a specific tumor, when exactly do you do a specific treatment? When do you give immunotherapy? When do you go to radiation therapy? When do you go to local regional? You know, the bottom line answer is you go to the MDT, and a strong MDT makes for strong outcomes and a strong institution in terms of success rates. And the reason for that is the team is variable. If you have a lineup of 100 hospitals, each of those hospitals will have different surgeons, different interventional radiologists, different radiation oncologists and machines. Asian is a perfect example. We have machines that other hospitals don't have. And to say that everyone gets CyberKnife is not really practical if you're in Mindanao and you don't even have a CyberKnife. You know? Of course, we want that business, but I hope you get the point. And in the same token, if you say everyone should get CERT, but there's no CERT in Mindanao, I can tell you that, then it's just lip service, but you're not really helping patients. So rather than look at guidelines and apply them locally, we really have to apply what's available. Now, going to the surgical side, there are surgeons who would refuse a resection for one patient, and only to find out that if you go to another surgeon, the surgeon says, well, I can do that. And, the patient really feels confused. No? But the bottom line is, the surgeon should be the one to say whether it's resectable or not another doctor looking at guidelines and saying, oh, your tumor is 4 centimeters, so this is not resectable. So that probably in a nutshell is the take-home point of this slide, that each each institution in each country. In fact, we by the way, we have our own local CPGs, but they're actually up for updating right now as we speak. So this is a nice slide. This is not mine. Disclaimer: it's from Duke, but it shows you what the lineup is, or what the armamentarium is for liver cancer. So I won't read it one by one, but the bottom line is some of these are administered by medical oncologists. Some of these are done by an interventional radiologist. Of course, surgery is done by a liver surgeon, a hepatobiliary surgeon. And of course, radiation is done by radiation oncology. Now, the bottom line is the goal of everyone, of all of us here, is to catch them early and offer a cure. And that's where local comes in. If you look at the left side of the slide, that's really the holy grail. If in a perfect world, we catch everyone early, we cure them, and we tell them, congratulations, you're cured and you don't have cancer anymore. But the reality is, with a setup where screening is not universal and there's low awareness, which is, of course, where the efforts are right now, you get a lot of these patients in the advanced stage. And that's where regional and systemic come in. Now, I will go through slides to show you what we can do for each stage, but the most commonly accepted algorithm in clinical practice is really the BCLC. It stood the test of time, and in fact, it keeps getting updated every 3 years. The latest update was in 2022, and this is the latest update. So it's a combination of looking at the Child-Pugh score, or the CPT score, and the size of the tumor. Of course, the ECOG status also weighs in. But the bottom line is, if it's very early stage, you always think about surgery or ablation first. I'll tell you in a moment what ablation is and how we do it. But surgery, it's easier said than done. No? We all know that. First of all, some patients do not want surgery, even if it's resectable. Some patients, what do you call this, are just biased against it because of previous experience, and we have to respect that. Now, some patients also will have lesions that are relatively small but are considered non-resectable. Some patients will have lesions that are very big, and the surgeon himself or herself will say that this cannot be operated on. The reason is, when you cut out a tumor in the liver, and this is more of a surgeon's talk, which Dr. Te will give. No? When you cut out a tumor in the liver, you cannot leave less than 30% of the liver remaining and expect functional capacity or situation compatible with life. So basically, it's a death sentence if you cut out more than 70% of the liver, with very, very few exceptions. So that's why ablation is also there. And for patients who cannot be resected, ablation is actually acknowledged as a cure, not just as a treatment, but a curative treatment. So again, I won't walk through these one by one because we'll talk about it moving through the slides. But the bottom line is, there's an algorithm, and this algorithm is not supposed to supersede in any way the decision-making of the patient and the MDT. This is just another slide. This is not the BCLC slide, but it is just a modified slide for places where there is a strong liver transplant program. Now, there's no question that we are not right now a major transplant center, but we are working toward that. And the reason we want to work toward that is, when you do not have a transplant program, realistically, the only patients you can cure are the patients who are completely resectable and very early. But when you have a transplant program, I'll use Tagalog, na kahit nakalat na yan sa atay, as long as it's not spread outside the liver, then actually you can potentially cure the patient by removing the whole liver, and realistically, you're replacing the patient with a brand new liver. So that's the reason we want to work toward that. And there are inroads to that. And in fact, we're doing transplants in the Philippines. We just haven't approached the levels of Western and other established centers like Hong Kong, Taiwan, Korea, and Japan. So a lot of people will get confused and ask, ano yung RFA, ano yung microwave? Now, they're both forms of ablation. And ablation is performed by putting basically to illustrate it, no? Putting an ice pick sized electrode into the liver, of course under careful guidance, and connecting it to a machine which does different things. If you do RFA, then the mechanism is different compared to microwave. It has something to do with the electromagnetic energy and the dipoles in the ions in your body. But the bottom line is nowadays, and to make it understandable to everyone, nung dati, nung way back, even before everyone's time, wala tayong microwave. No? We used to have convection ovens, and in the Philippines, we used to cook rice under flames, di ba? Yung kukuha ka ng kahoy, magsisiga. And imagine comparing that to microwave nowadays, where you just press a button and in 1 minute you have a cooked egg, for example, or hot water. So that's pretty much the difference that microwave brings. It allows us to do treatments in 1/3 of the time that RFA used to take. If you can see on the slide, the procedure time is more procedure time, less procedure time. That's an understatement. It's actually more than half time savings. When I was a fellow, I was lucky enough to be training in the tail end of the old RFA era, and at the same time, pumasok na yung microwave during that same time that I was fellow. So the earlier part of my fellowship, we were still doing RFAs, and whenever we had an RFA of the liver, it would be a whole day process. No? You'd be the fellow assigned to that case. Sa umaga pa lang, naghahanda ka na, makakalabas ka hapon na by the time you finish the liver. And that's just for one lesion. Nowadays, we can do 4 microwave ablations in a day if we want, no? Because it's a lot faster. And it actually has some other advantages. No? The critical structures adjacent to the lesion are sometimes contraindication for RFA, and microwave can go against that. This is how we do it. There are people who do purely ultrasound guided ablation. I'm not a fan of that. It's not because I'm biased, but because if you only do ultrasound, you're missing out on the bird's eye view, basically. Anyone who's done ultrasound knows that when you do an ultrasound, all you see is whatever's under your probe. It's like looking in a dark room with a flashlight versus looking in a dark room with floodlights. And that's what the CT guidance gives you. And you can see that here. This is how it looks in real life. The patient, of course, is draped under inside the hole, inside the donut hole of a CT scanner. And you have that electrode stuck into the liver. And we look at the electrode before we turn it on and connect it to a machine. This is another example where the lesion was in the dome of the liver. Back in the day, I used to hear colleagues tell me, basically quoting off books and journals, that lesions in the dome of the liver cannot be ablated. And the reason why that used to be a misnomer was that when it's in the dome of the liver, as in this case, there's lung right here in this dark area. Everything that's dark, at least in the middle picture, is lung. And you don't want to puncture the lung, of course, going into especially with what I call an ice pick sized electrode going into the liver. That's going to lead to pneumothorax, and the patient will end up with a chest tube. So before, people used to say, ay, pag nasa dome, hindi pwedeng ablation. No? Kailangan surgery yan, or ano na lang, we'll just try to treat it, but we can't cure it because it's too high up. That's not true. No, when you have a complete set of tools, what we do in a case like this is something like what you see here. No, you can see the lung better in that bottom image, where we inject air first, artificially or intentionally, into that thorax to move away the lung and create a window where you can puncture at will without puncturing through the lung and not causing a hole or an air leak in the lung. So it takes more effort, takes more experience, but it's definitely worth it when you can offer a cure rather than tell the patient that, sorry, it can't be done, and you have to rely on local regional treatment that will hopefully delay the progression. This is an example of how it will look if you do it correctly. After the treatment, before it will usually look as Dr. Berlingo, no, showed you, the enhancement pattern is key. No? That's a typical appearance of HEC. Matingkad siya on CT, MR imaging. But when you've treated it, it's still there. There's an abnormal area there, but it's now dark instead of bright. So we're going toward the end of ablation, but really there are very few absolute contraindications. Obviously, ablation, as you saw in the earlier slide, is done for early disease. So if it's late disease, it's not a contraindication, but you're doing a patient a disservice if you're trying to promise them a cure with ablation, knowing that it's spread already in different parts of the body. The other ones, decompensation is obvious. Now, if you're about to succumb to hepatic failure, then there's no point in going for something that would cause more morbidity. But the other contraindications are actually relative, no? And you can stretch the envelope, if you will. This comes up during the MDT. Some people are more willing than others. Like, for example, I don't intentionally like it, but I've done 5 lesions in one patient once. And it's really a labor of love. No? Kasi imagine 5 times yung oras. No? So I spent 7 hours with that patient trying to burn everything. And that's the practical reason, no? That more than 4 lesions this year. Because on a large scale, you don't want to take on all these patients and do each of them for 7 hours. Coagulopathy, of course, is correctable with hematology support. And the proximity, again, is something that you can deal with by pushing away the heart with fluid artificially injected, or pushing away the lung, as you can see here, with air. So we'll now go to the next set, which is, if you remember the earlier slides, no, we go to local regional treatments, yung CERT and TACE. Now, CERT and TACE are a different animal. Instead of putting a needle through the skin into the liver, we go in with different sizes of tubings, and once we've selected the hepatic artery, we inject different materials. So just to make it crystal clear, it's the principle in liver tumors is basically like a child getting financial support from 2 parents. No? So everyone, all of our livers are perfused by 2 blood supply systems, the portal vein and the hepatic artery. The portal vein is blood coming from your intestine, and the goal of the blood from the reason the portal vein is there is not really to oxygenate your liver, but more to carry the blood from the intestines for the liver to detoxify it before it goes back into the general bloodstream. However, that contains oxygen also and serves a purpose. Now, the hepatic artery is a direct branch of the aorta from the celiac trunk, and the characteristic of tumors, of liver tumors, and especially of HEC, is that they grab their blood supply from the hepatic artery more than the portal vein. And that's what we employ when we do this. Because we cannot catheterize the portal vein from superficial route, but we can catheterize the hepatic artery. So that's where the strength of interventional radiology lies. Having said that, if you think about it, it's like, it sounds funny, but maybe it helps drive home the point. No? May mama's boy, di ba? Yung makananay yung isa. And that's what liver tumors do. They rely more on the hepatic artery than the portal vein. And that's why by plugging off the hepatic artery, you do more damage to liver tumors than to the normal liver. And it serves us well. So you can read through the slide, but basically there's a difference between CERT and TACE. I'll tell you also with colorful words, no, the difference. When you do a CERT, you're basically relying on a radiation cloud from millions of particles, hundreds of millions of particles in the tumor. So for our radiation oncology colleagues, I think everyone is familiar with it. No? It's actually a form of brachytherapy. But instead of a single source, you're injecting millions of sources, and they're left there permanently, not unlike most brachytherapy where you take out the source physically after. You just allow it to decay in this case. So the source in this case is something that's manufactured, unfortunately, abroad. No, we don't have a manufacturing facility for spheres, which are yttrium particles. In fact, in the whole world, there are only 4 production centers: Frankfurt, Singapore, Sydney, and Massachusetts. No? So wherever you are in the world, your source of yttrium, if you have a cert, will come from one of those four places, literally by plane, before your treatment. So that's what happens here. No? When we have a cert patient, we have a simulation. The patient is checked first by the interventional radiologist with nuclear medicine versus any contraindications. And then when it's a go, we order the spheres from Singapore. They literally fly it on Singapore Airlines a day before the treatment. And figuratively, the nuclear medicine department unpacks it and prepares it for us. And then I inject it in the cath lab. It's a very expensive procedure, costs more than 1 million pesos to do for the liver. Now, I'll talk a bit later about the indications. The taste, which a lot of us are familiar with, it looks like this, by the way, the image on the slide. This is doxorubicin, that's why it's red. And this is the lipiodol, that is used to dilute the doxorubicin and keep it in the liver. The goal is different. You're not relying on a cloud, but you're relying on actual delivery. So it's a little bit analogous to trying to cause a mass casualty by poisoning versus trying to cause a mass casualty by lethal gas. No? In lethal gas, just by being near it, you'll probably end up inhaling it and be affected. But if you're trying to poison someone, kailangan kainin. No? So it has to be taken up, and you have to get into that blood vessel that goes to the cell. And that's where taste fails sometimes, because if the interventional radiologist, for whatever reason, is unable to reach every single blood vessel that's perfusing the tumor, then there will be some portions of the tumor that are still alive after. Because you can't really expect a residual cloud effect that you get with CERT, by the way. That's one of the advantages with CERT. Kahit hindi mo nasapol, as long as part of your particles were very near, there's still a cloud of radiation that will kill the adjacent tumor. Also, very important. Taste also, just like chemo, it's a form of chemo essentially. It's a combination punch. We don't advertise it to the patient as a one and done kind of thing. Although we sometimes have cases like that, we have to prepare the patient that it's very possible that down the line there will be recruitment of new blood vessels, and we need to do another treatment. So similar to chemo, when we medical oncologists talk to a patient about chemo, you never tell the patient, I'll just give you one infusion and then we're done. You always tell them it's like boxing. We're gonna play 12 rounds and we have to win all rounds to beat the tumor. So this is how it looks in real life. This is an actual case. We have the patient in the cath lab. It's basically an OR setup. We have the patient fully draped and we catheterize the right groin. We go up to the liver, and under fluoroscopy, it's actually digital subtraction angiography, we select into the liver and we isolate the area where the tumor is. The principle is the same between certain tastes initially. You do an angiogram and you localize and you select, meaning you don't want to be injecting as much as possible into normal liver. You just want to be directing everything you inject into the tumor, and that's what you see here. So there's what we call conventional taste, where we use that lipiodol. It's oily material that lodges in the blood vessels. And there's also different kinds of taste called drug-eluting bead taste. Yung drug-eluting beads, this is actually a Western invention. No? Taste, by the way, was invented in Japan. And they invented it with the oily contrast, the lipiodol that you saw in the picture. Now, the drug-eluting beads were an offshoot of people in the West, in the US specifically, thinking, what if we create different sizes of beads that will fit different vessels? And the principle there is by loading the chemo drug on the bead, there's supposedly a slow release. For those who went through cardiology rotations, it's like a drug-eluting stent. Through time, unti-unti rini-release yung drug, hindi biglaan. But the bottom line is the outcomes are very similar in qualified hands. It's just a matter of the availability. Here in the Philippines, I'll have to admit to you, mas widespread ang availability ng lipiodol, conventional taste. So that's why you'll see it a lot more. No? So again, this is actually a case I did yesterday. I just added it to the slides. No? The patient, if you look at the imaging again, if you remember from the earlier lecture, there's wash out on the left side images. Initially, it's whiter. That's the hallmark of a hypervascular tumor. And if you look at the bottom image, the round lesion, that large tumor there is darker. So that's what you call washout. And that's the hallmark of HCC. Now, if you go to the angiogram, what you see is what we call tumor blush. There's a lot of intense flow of blood to that area. Or again, to use Tagalog, no, mas matakaw siya sa dugo kaysa sa other areas. And the principle there is if you reach that vessel supplying that tumor, then you can inject whatever you want. In this case, we used conventional TACE. And what I did was I intentionally went for the upper part first. Now, this is a very large tumor. So what we are doing in this case, this is a work in progress because I just did it yesterday, is a stage TACE. If you have a very large tumor, sometimes you can't eat all of it in one sitting because you will overdose on the doxorubicin and even on the lipiodol. So what we did in this case is we went for half, and I will be bringing this patient back within the next month to go for the other half at the bottom. This is how it looks on another patient, where this was actually with drug-eluting beads naman, no? in another patient. And if you look at this outcome, this is crystal clear, I think, to anyone that there's a tumor here and it's fully coated with the drug. This patient had a beautiful outcome. This is one of the cases where we actually had a complete response, complete necrosis of the area. If you see here, there's zero enhancement, complete necrosis, complete washout. I'm sorry, not complete washout, but complete absence of any flow in that area. So that's what you aim for in a perfect world. This, very quickly, I'll run through this. This is what I was talking about. When we talk about a safety check for CERT patients, this is unique to CERT. We have to check whether there's any flow of particles to the lung that will occur in a dangerous proportion. The reason for that, the reason it doesn't apply to TACE is because the particles that we use with CERT are much smaller. We go for around the 90 microns in size. Actually, 10 to 90 yung what do you call this? Albumin in microns that we use to test for the shunt. And when we do TACE, the particles are actually larger than 100 microns. So there's more of a chance of shunting into the lungs than with the CERT or with the radiation beads that are all manufactured to a specific size than there is with TACE. And of course, the goal here is to avoid a patient that has a good response in the liver, but where the lungs are torpedoed and you have radiation pneumonitis and the patient succumbs to respiratory failure. There's another problem with CERT that we need to check for is the possibility of particles, scattering out of the liver. In TACE, actually, that's a little bit forgivable to a certain degree, but in CERT, it's a precise science. No? You can't have just a few particles go into the bowel because that will cause an ulcer. Remember, there's that cloud effect I was talking about. So you end up burning a hole into the bowel, and that ends up being a cause of death, no, for the patient, and sometimes major surgery. So that's the other thing we check for. So here we go. Contraindications. Similar to ablation, you don't want the patients who are already on the brink of hepatic failure, decompensated cirrhosis, just another word for that. When you have severely reduced portal vein flow, this is another code name for portal vein thrombosis, then we give pause and we have to look at the cause for the thrombosis. If it's something that will respond to radiation, sometimes we send the patients to RT first if it's a tumor thrombus, because that responds well to a high dose of radiation. Now, the relative contraindications are something that can be overcome by a qualified team. Renal failure, of course, is something you need a nephrologist for. Cardiopulmonary depends on the degree of involvement of the coronaries, and the varices can be banded, no, by endoscopists. But it takes a village to do this. This is just one slide I grabbed for another lecture to show you what we look at. No? This is always a dilemma because a lot of times we do these treatments, we do CERT or TACE, and then we get a report from the radiologist saying that the lesion has gotten bigger. But really, what the radiologist is looking at is the dead shell of that battle zone, which looks bigger. But as long as there's no enhancement, then that's fine. You'll always have a scar of necrosis, and even if that scar is big, that's okay as long as it's dead. So sometimes there's a lot of panic from the patient when they get the report from radiology. They can sometimes text me at night saying, "Doc, lumaki daw yung bukol. Nag-treat ako, lumaki lalo." So it's just something to be aware of. No? The lesion will always, as you can see in the slide, always be larger within the first 3 months. Now, very quickly, portal vein thrombosis used to be an absolute contraindication, but nowadays, actually, neat tools that we have in our arsenal that we can use to suck these out. Now, there's what we call thrombectomy with the vacuum device that we can use. You puncture the liver directly from outside, of course under image guidance, and you put in. It's the same mechanism we employ to treat massive pulmonary embolism. We've had some dramatic saves here for pulmonary embolism where we come in, the patient's desaturating, and we come in with a vacuum and vacuum out the clot from the saddle. And sometimes we can save the patient. That's the same principle that you can use, but only if it's a blunt thrombus, not if it's a tumor thrombus. So if it's a tumor thrombus, the default reaction is usually to look at it with RT and see if we can re-establish flow. These are my last two slides. Just to share with you, during the Fukushima disaster, there was a lot of publicity around the Japanese where they sent the senior citizens to rush into the cleanup zone since there would be more casualty if the younger people came in. And the reason I place this is really, CERT and TACE are actually high radiation procedures. Imagine we spend 3-4 hours in the cath lab under video x-ray. For a patient, it's radiation that's acceptable because they only do it once, twice, 3 times in their life. But for us, if we do it every day and we don't wear a lead gown, obviously we won't live that long. So it's a hazardous job, and if you look at our job and our specialty, it's really male dominated. The other small side reason is realistically, if you're pregnant, for our female colleagues, you have to stop the work in the cath lab for a while. And imagine if you're planning to have 5 kids, it's actually 5 years of your life that you're not working in the cath lab. So I intentionally did not include, I can make a whole 3-hour talk about the combination therapy and all of this. I think this is better placed in Dr. Pat Du's open forum mamaya. We can talk about that. And third, he can come in with the status with trials, because trials are proceeding at breakneck speed. There's a new trial that came out what's that European meeting, ESCO, just last week, Talent Taste came out, and basically they're seeing significant benefit with combination therapy. But the bottom line is that my take on this is, if you want to do combination therapy with immunotherapy, the TACE is usually better done first, or the CERT is better done first, because when you start with immunotherapy and you have bevacizumab or durvalumab, even the surgeons will say, no, you don't want to operate right after. You want to rest first and take usually 4 weeks off the immunotherapy before you make an incision, and the same way before you put in a wire into the hepatic artery. And the reason is, when we put a wire, we sometimes encounter dissection, which closes off the blood vessel, and it ruins everything. We can't do any treatments in that case. So I think that's the last slide. Thank you very much. I know there might be some questions, but we'll reserve it for later. Thank you.
Thank you, Doc Habito, for that insightful talk on TACE and SIRT. And let's reserve the 3-hour talk, Doc, next time. We'll present the same certificate to Dr. Cicero Matthew Habito, given this 25th of July, 2025 at Asian Hospital Medical Center. Audiences, please reserve your questions later for the final forum. This certificate is signed by Dr. Nilangel and Dr. Nivera. All right, so let's welcome our next speaker, Dr. Catherine Te, a respected surgeon to discuss liver surgery and transplantation in HCC management. She is the first woman to chair the Department of Surgery at the National Transplant Institute, former director of the Liver Care Cancer at Makati Medical Center, and the president of ASEAN Laparoscopic HPB Council. Dr. Te is also a founding member of several prestigious and surgical societies, both locally and internationally, and the only Asian woman to be accepted at the Elite Society of Surgeons Les Compagnons Hepatobiliarii, if I pronounce that correctly. Beyond surgery, she champions accessible healthcare, founded the Samahang Magmamahal sa Atay Foundation, and helped shape the National Integrated Cancer Control Act, a landmark law for cancer care in the country. Today, she continues to lead the efforts in policy, surgical training, and equity as a chair of board of the Philippine College of Surgeons in Cancer Commission. Please all welcome Dr. Catherine Te.
Good afternoon, everyone. Thank you very much, Roy, for pitching in and doing the talk before me because I was stuck in the Palace and PSGS convention because it's also our convention in Shangri-La. And my session was delayed by 45 minutes. But nevertheless, I'm here. I just hope my slides work. So I'm going to focus on surgery, on the surgical management of hepatocellular carcinoma, which is the gold standard for the treatment of HCC. Okay. Right. So this is one. He's 49 years old with a 28 centimeters liver mass. No screening, no early detection. It was discovered because of pain. And here is Juana, 42-year-old teacher. She's an elementary school teacher. With underlying hepatitis B, again, no screening, no early detection. So she thought she was getting pregnant at the age of 42 or getting fat. So only when there was pain and other symptoms, and she got herself diagnosed. So please do remember these two patients. And I'm sure that nawala. I'm sure that you would have encountered these kinds of patients in your practice, in your management as well. Sorry, it's quite hard to talk about surgery without my pictures. So the next one that I will show you, which is even worse, is actually Right. So this is Juana, the 42-year-old Hep B teacher who thought she was getting fat, or and only when she had pain when she got herself diagnosed. And this one is a 23-year-old young lady who presented with amenorrhea, for which she thought she was pregnant. And she was opened, and they realized it was not ovary. They closed the patient and sent them to me. We resected this 5 years ago, and she has been well since then. So these are the kinds of patients that we are seeing. And as I've said, you probably are seeing them as well. Despite the BCLC, despite all the classifications and all the awareness, we are still seeing these patients. And using the BCLC, they're at the advanced stage, large HCC. Many of them have portal vein thrombosis. And if in our setting, utilizing systemic treatment is almost not possible in many of them because of the cost. This is really the global burden of primary liver cancer. And it's not only in our setting, but majority in Southeast Asia. This is really a challenge. Liver cancer that's arising from hepatitis B. And nowadays in the West, it's liver cancer arising from fatty liver that is also becoming more predominant. So HCC is actually at the crossroads of precision and poverty. Precision because we are gearing more towards precision medicine and even surgery, as you will see later on. We are talking about doing precision surgery. Yet, when poverty strikes us, and I know Dr. Ngelonghel has been very much involved in a study on the economic impact of cancer on Filipinos. And this is the reason why that we must act, and we must look into how we can further our screening, prevention, and early detection. Despite all the advances in liver surgery, as you will see, all the way back from the early 90s until today, with all the different drugs, different modalities, and evolution, the most important really is that we are improving our surgical outcomes despite the challenging cases, because we have better systemic treatment as well. There is the advances in all the systemic treatment, apart from sorafenib and lenvatinib, beyond the chemotherapy era. And we now have deeper understanding of tumor biology, although tumor biology of HCC is quite diverse and heterogeneous. Even in the same HCC, we have a very heterogeneous tumor biology. And last but not the least, better patient selection. I think this is also one of the reasons why, Roy, you showed earlier in your taste, one of your patients had a very good response. But most of our response in taste with majority of the patients are not that great. It has something to do with the tumor biology. And therefore, it's important that we exhaust and maximize and optimize the feasibility of surgery in HCC. It is only through understanding the tumor biology that we would be able to offer more for these patients. And there are certain quality indicators to achieve HPB surgery, quality HPB surgery. And then first and foremost, we need at least 2 certified HPB surgeons. So we've worked so hard to come up with these core sets of indicators, and a specialized MDT, meaning not an MDT that is for all types of surgery or all types of tumors, but specifically for liver biliary tumors. And then a satisfactory institutional case volume with synoptic pathology report, undertaking of unplanned reintervention procedures within 90 days, meaning M&M within 90 days should be reported, including the post-operative bileak and the Clavian-Dindo grade 3, more than grade 3, and 90-day post-procedural mortality. So all of these are important indicators for HPB services or HPB surgery, which brings us to the availability of special services on site, which requires endoscopy, interventional hepatobiliary radiology, dedicated medical and radiation oncology, dedicated HPB and liver pathologists, dedicated HPB and liver transplant nurses, nuclear medicine, and all the other palliative and pain services. We need, of course, appropriately equipped OR, critical care, and the full diagnostic imaging on site. Ideally, we need to have liver transplant facilities 365 days a year, because if liver resection fails and the patient needs a transplant emergency, at least we have that capability. So with the involvement, with the improvement in our outcomes, we push even further, and with the evolution of all the available technologies, we are seeing more and more and doing more and more of these complex high-level surgeries. Yet we are still facing all the challenges. These are all the challenges that we see because there are so many patient factors. Remember that when we are treating HCC, we have a background of cirrhosis. So you're treating actually two problems, cirrhosis and the tumor. And there are so many anatomical variations. The liver is the only organ, the hepatobiliary is the only organ in the body that has so much variation in terms of vascular and biliary anatomy. And tumor characteristics, as I mentioned, the heterogeneity in the tumor biology, and also social determinants of our patients. Expertise, of course, these vary amongst different institutions. We can't have them all, but we hope that we wish that we could. Politics, politically, and policies, in particular, governance. We need, these are mainly our challenges in terms of finance with the RUVs, and also policies on vaccination, screening, and disease prevention. And now more importantly, I think, which all of us are facing, are institutional factors because of the limited infrastructure and resources and challenging processes and flows in our systems, and availability of all the services that I mentioned earlier. And this is an example of the quality of scans that we need, yet we do not have them. We don't have them here. In order to perform very good quality CTs, surgeries, we need good quality imaging because we scrutinize and we look at all the vascular and biliary anatomy so that this can guide us in our surgery. Likewise, we need good teamwork because no matter how skilled and confident we are, which is what I felt, I kept upskilling myself, but I cannot understand why we are failing. We are not getting the results appropriate because our anesthesiologists have not upskilled. Our radiologists are still doing all the poor quality scans. Our nurses don't even know how to assist us. Everyone in the team really needs to cope and upskill to be able to achieve the standard of care that we want. And we need to learn how to trust each other because mutual trust failure is almost certain if there's no mutual trust. In the OR, sometimes you will see that the surgery went on so well, you appear like the surgeon is so good. In reality, it's the anesthesiologist who's very good in limiting the fluids and keeping a very low CVP. And the nurses preparing all the necessary things. So great teamwork is absolutely necessary. Let's go through a couple of cases which in the past would probably have been really not possible. But for example, in this 70-year-old female with the sudden onset of jaundice and dyspepsia, initially unresectable, you'd see with a PIV count 1,600 plus, preoperatively received atezolizumab prior to surgery decided during the MDT, and post 6 cycles, this became resectable. To me, I think it became resectable because the size shrunk a little bit, that I was able to save more liver, so I have better liver function, liver volume left. However, this is a very advanced disease because the patient had tumor thrombus. and the biliary tree. But then we still proceeded and did an extended right hepatectomy for this patient. And the patient has been alive with no recurrence for a year, I think, which is pretty good for this. And this is also another case that's very, very advanced also with the tumor encroaching the hilum that was read by our radiologist as Klatskin. In reality, it is not Klatskin. It is an HCCCA, a combined hepatocellular cholangiocarcinoma that encroaches into the hilum, and it ended up with a six biliary enteric anastomosis. So I had to do this like I don't know, the white things that you see there, those are the bile ducts. So I have to anastomose each and every one of them, 2 millimeters, 3 millimeters, and it was really a challenging case. Thankfully, the patient survived and has been alive and with no disease for the past 8 months. So I hope it continues to be good. So we are continuously seeing patients with BCLCB, BCLCC, and yet I don't know how we can change this landscape. And in the past with BCLCB, and even if you look at the Barcelona classification, BCLCB and C are contraindications to surgery. Yet we keep pushing and still doing surgeries for these patients because there's just no possibility. These are poor patients, as I mentioned, Juan and Juana. They have no possibly any possibility to take in systemic treatment. And we know for a fact that in a study back in 2008, multiple tumors nor portal hypertension are surgical contraindication for HCC. However, they independently increases the risk of recurrence. So this is something that we just need to keep in mind and to tell our patients that the risk for recurrence is high. And these are all the challenges against BCLC, where we show, which actually showed that 5-year survival can still go up to 57%, and in Hong Kong, 51%, and also another study up to 43% versus no surgery at 5%, at 15%, and 18% with local regional treatments. So liver resection in Asia, at least in Asia, is widely applied even in BCLC-B and C with good short-term, and sometimes we're lucky there are long-term results. So I'd focus a little bit on the intermediate to advanced stage because this is really what we see mostly. And in a series of our patients, which we published in 2015, 48% are stage B and C, size 4 to 33 centimeters, were male, 65% were male, and age more than 60, though mostly are still child A. Hepatitis B is about 60%, and as you see, the sizes range from a golf ball to a watermelon size. And AFP can be, mostly are less than 1,000 in 75%, and that tells us that PIVCA2 probably should plays a role in the use of tumor marker to detect earlier to HCCs. Mostly have mild cirrhosis and intermediate cirrhosis with 17.5%, very, very cirrhotic. A majority are on the right, and 62.5% of them have lymphovascular invasion. And all of these have underwent liver resection. And the difference really is that these patients with lymphovascular invasion have the higher recurrence rate. Incidence of recurrence is at 30%, with a median overall survival of 35 months. Now, in comparison with TACE, whom we see an overall median survival of 8 months, and this is in patients who are more advanced, not the early HCCs, 30% of the patients have already died after 35 months. So those patients who undergo surgery have a longer overall survival of 35 months. And we also see a high rate of TACE refractoriness in our set of patients. Now, what is the economic impact to the Filipinos? Still, surgery is the most economical, I would say, because even though we do taste, it still needs many times different sessions, and of course SIRT is exorbitant, and systemic treatment is equally expensive. Now, open or lap, it really depends on the availability, the expertise, but at least we know that the expense can be curative at the minimum. The chance for cure is higher. We also have the experience to do ALPS, where we do a stage liver resection, and still the cost of this is much less than SIRT, and probably friendlier to our interventional radiologists with lesser exposure to radiation, and the cost can be kept at more acceptable. What is the impact on quality of life? We know that looking at all of these, our study, this is also from our patients, regardless of approach, whether it's open or lap, the patients achieve emotional scores, the same emotional scores by 1 month. Meaning they're happy, they feel good that they have undergone surgery, and thus we know that major resection experience a higher impact, and that HCC has a significant and potential adverse impact on physical health and psychological well-being, because these patients have mentioned about the fear of being excluded by their friends. And patients who have an established diagnosis of HCC experience a wide range of negative emotional symptoms such as sorrow and fear of death. And so goes down the line where they receive strong support from their spouses. And of course, laparoscopic approach proved to be superior, especially the first 30 days after surgery. The only limitation we have here is that there's no direct comparison with those who were treated according to the BCLC guideline. And there's always the diverse tumor biology, and we also didn't look at preoperative treatments, whether the patients have received preoperative TACE, RFA, or TARE. And I can say that our approach really is liver resection is preferred whenever technically feasible, meaning we have enough remnant liver, at least 30%. If not cirrhotic, if patient is cirrhotic, we need at least 40% to be on the safe side. So theoretically, unresectable single HCCs outside of Milan, we still resect them, and even multinodular HCC confined to one lobe with enough liver volume are also still candidates for resection, even with vasculobiliary invasion. I'd probably say that we have a more aggressive approach than the rest. And overall survival is significantly better than other forms of treatments. And this is the algorithm that we use. This is very personal. It's not in the guidelines. It's very personal because this is what I have developed over the years based on our experience in patients with ascites. If on diagnosis there's ascites, we stop. We don't do anything. We know that the child score is high and liver failure will be high. In patients with no ascites, we send them to the GI to do an endoscopy and check for esophageal varices. If there is grade 2 or grade 3, we treat and reassess. If it's grade 0 or 1, we proceed with surgery. We also have been using FibroScan as another test, and in patients less than 12 kilopascals are also considered as good surgical candidates, even if this is moderate to F2 to F3. And then we look at the bilirubin levels. If the bilirubin levels is more than 2, no surgery. Which is the same in SIRT. When you have bilirubin more than 2, we also don't want the patient to undergo SIRT. But in patients with BIL less than 1 or 1.5, we're able to do major liver resection. But with patients with BILs 1.5 to 2, we can only do very limited resection, and better to do it laparoscopically if possible. So this is a very personal approach, and hopefully we would be able to complete our numbers and come up with our series of publication on this. And just off the press, July 23, I've just, as the senior author of this paper, we've just published Asia Pacific Modified Delphi Consensus Conference on Large Hepatocellular Carcinoma, building on our experience with large HCCs. And as you see, even patients with PVTs can undergo surgery with 100% agreement and single multiphasic contrast enhancing radiology, or CT or MR in combination with AFP of more than 400 is sufficient to diagnose a single large HCC. And large HCC is defined as more than 5 centimeters. So these are very, very new. Just as I've said 2 days ago, yeah, we just off the press. So surgery, major hepatectomy, would be performed even with portal vein thrombosis, and the anterior approach in combination with hanging maneuver is the safe choice in the resection of HCC. So these are, because even in the operation, the technique, the approach is necessary. When you manipulate the liver too much, you squeeze the tumor out and result in systemic dissemination. So the anterior approach is very crucial because we do not touch the liver, we do not manipulate the liver during the surgery. We open the parenchyma and continue from there. So with the evolution of technology, we are able to proceed with do more and more laparoscopic liver resections, minimally invasive, which I won't bore you with this because it's very surgical. And the first consensus, the second consensus actually that we held in Morioka in 2014, have shown us that this is definitely feasible even in larger tumors, because the earlier ones were limited to small and peripheral tumors. So now we have a difficulty score with a difficulty score of more than 0 to 12, so we can limit and instruct our juniors which are the possible case, and for non-experts, which are the cases that they can do in a difficulty score of 0 to 3. These are for the non-experts or the newbies, but intermediate, advanced, and expert cases should be done in expert hands. The 2017 Asia-Pacific Consensus Statement on laparoscopic liver resection for HCC have focused on the minor liver resections, as I mentioned earlier. Very little evidence on major hepatectomy, and there was, in terms of patient selection, there's no difference with open hepatectomy, and it is important to note that here, again, centers of excellence was mentioned, and that these surgeries should be done in centers of excellence to avoid complications such as risk of rupture, oncologic compromise, margins, and also looking at the delivery of the tumor. So what do we mean by centers of excellence? That means we have a dedicated multidisciplinary team where centers perform at least 30 lap liver resections per year, and that the surgeons must have performed at least 100 lap liver resections on their own over a lifetime, and at least 20 cases per year. So this is what we ask for strictly for our surgeons, because we don't want to see any disaster happening in front of us. So I'm going to skip this portion because it just tells us that most of them lack evidence in terms of laparoscopic approach for portal vein invasion, and also the use of some other newer innovative technology. In terms of open and lap, definitely less blood loss, less transfusion rate for lap, shorter hospital stay, and better 1, 3, 5 years overall survival. And there's no significant difference for 3 and 5 years disease-free survival. We also have, in some of these studies, we found that the best patients actually who would benefit from a laparoscopic liver resection are child pube B. The more cirrhotic the patient, the more advantageous the laparoscopic or the minimally invasive approach is for them. So we've seen this in these multi-center trial. So child B7 cirrhosis are the best candidates to exploit the benefits of minimally invasive approach. In terms of large HCC, still it's the same. Since we have had the consensus published 2 days ago, all of these now that I'm going to show you will be or are immaterial because the publication was based on all the previous work that we've done. In extreme cases, portal vein thrombosis, IVC thrombosis, biliary thrombus as well, we do. So this is an example of how we do it laparoscopically and extracting the tumor. And if it is a portal vein thrombus, we prefer that we do a graft, and this has a better disease-free survival. So you'll see here we are releasing the tumor and trying to take it out from the bile duct. So I'm gonna move on to, let me show you this one. As an example, why multidisciplinary approach in liver cancer in HCC specifically is really absolutely necessary. This patient is very cirrhotic and came with a large tumor, not resectable because there's no remnant liver. So we send the patient to IR to do SIRT, and the patient also received lenvatinib as a systemic treatment. And the tumor shrunk from 14 centimeter to 9 centimeter after those two strategies, and then subsequently received this treatment because SIRT has the side effect of hypertrophy of the contralateral side. So the contralateral side increased, the left side increased in size, and so we were able to proceed to resection of these patients. And what you've seen, I think earlier, the green one, is the fluorescence guided surgery, which we do a lot, almost SOP nowadays, is because it guides us in our transection line. When it comes to anatomic or non-anatomic, there's no big difference, but best to do an anatomic approach for liver resection, for HCC. And I'll skip this in the interest of time. And again, all of these just shows that minimally invasive liver surgery improves resection outcomes. So again, this is another, just to show you how a minimally invasive approach can be done and can be very beneficial to the patient, especially in very high difficulty scores of Iwate 10. You see there, it's possible to do it, and it's actually beneficial for the patient, not beneficial for the surgeon because it requires a lot of calisthenics, I think. But the robotic approach nowadays is better. So over the years, we've been able to achieve better outcomes, and today we also apply robotic surgery, and I think we now have achieved 536 hepatectomies with 2.9% mortality, which happened during the old days. In the open days, we have zero mortality in minimally invasive, not only because of better patient selection maybe, but also because the laparoscopic approach or minimally invasive approach really offers a better chance, especially for child B cirrhosis. And these are our cases, as you see, from open previously in 2014. Mostly are open, the blue ones are open, and now it's coming down, while the minimally invasive, which is the yellow one, the green ones, are increasing in number, and we have started doing robotic only last year. So there were only 7 cases done last year, but we've done much more this year. And we have a very high difficulty score. 72% is difficult Iwate, more than 7. And that's why I'm saying this is really a result of poverty and probably poor education, such that we need to really educate our lay people, our patients, and their families, because this becomes a challenge for us. Technically, it's more difficult to control the bleeding with big tumors. Transection planes are also challenged. Of course, eventually our overall survival and also disease-free survival. Another challenge is because we need a lot of technology infrastructure. It's technology driven, highly technology driven. We need very, very good quality scans for preoperative planning, and we need intraoperative, very, very good, reliable instruments to perform the surgeries, including intraoperative ultrasound, which is an SOP. And I always tell the surgeons, you have no right to do surgery without intraoperative ultrasound because you won't be able to map it. You won't be able to map the vascular structures. And you see here the green, this is the fluorescence, which the bile duct, where we have an anomalous bile duct that was seen on MRCP previously, and we are able to track it intraoperatively to avoid a disaster in the bile duct injury. And this is also, I mentioned earlier, the demarcation line. So you see, once we have occluded the Gleason's pedicle that is supplying the tumor side, then we inject the ICG. You will see that the liver is fluorescent green. The fluorescent green part is to remain with the patient while we remove the non-fluorescent part, which really gives us a very, very precise demarcation line. So you will see here that why is it important to have that very precise transection line is, number one, oncologic margin, because we know we are doing this anatomic resection. Number two is that to avoid liver failure, to avoid congestion of the liver and unintentional resection of tumors or of liver parenchyma that is unnecessary. So you see there's a nice demarcation between the fluorescent and the non-fluorescent part. So this is how technology helps us in achieving better outcomes. And even after surgery, you will see, oops, sorry, it's okay. You will see perfusion. We check with perfusion with the fluorescence to know that the liver is very well perfused. Just to show you our approach, which highlights the how we choose between open and lap. And finally, how we choose our patients is defined by this mnemonics, which is again very personal because we make sure that the patient has a very good ECOG status, and then all the associated comorbids. We check the Charlson Comorbidity Index, check the FibroScan if it's less than 15 or less than, previously was less than 12. Now I think we become more aggressive and it's less than 15. Functional liver remnant and also the child and MELD score. And then we use fluorescence. E is for extent of disease, for example, extrahepatic metastasis. T is teamwork, which is inclusive of MDT and the treatment strategy, whether it is resection versus transplant versus local regional versus systemic. And then at the end of it, we ask why. Why do we want to operate? Why? What are the pros and cons? What are the risks and benefits? We ask a lot of questions, including patient goals, because we don't want to operate just because we want to operate. It's important to note that in the real world, resection, in our real world, resection is still the most economical and still the best option available if the patient doesn't, especially if the patient doesn't have the resources. This is our local HEC CPGs. I hope we are all familiar with it. And you can just go through the publication that we have included. I think this is it's in many of the local journals, I think. Gastro, the gastroenterology, the PCS also, and also the medical, the IM. What's really important here that I would, before I transition to transplant, is that number 4, there is insufficient evidence to recommend liver transplantation over liver resection in early stage hepatocellular carcinoma. I started with the intermediate to the advanced stage because that's what we see most often. It's very rare to see early stage, but in early stage, liver transplantation is one of the recommendation in the Barcelona, in the BCLC classification. But to us, there's insignificant or insufficient evidence because of the cost, I think. And also, it's not being done often. Likewise, in America, if you see the recent consensus process, this was published in 2020. And you see LDLT also, if you see there, is inconclusive. So it's, thank you, it's really not yet, not very common to see a high volume of living donor transplant. Much more DDLT, because they will be dropping out of the waiting list in a DDLT. But with an LDLT, if they have a family member who is willing to donate, that will be their best chance in a high volume center. So now I'll show you. This is also from the same publication. This is in America, and it's very, very recent. As I said, these are the patient and tumor characteristics where the different different types of modalities can apply, from RFA to DDLT to LDLT as well, including minimally invasive resection, of course. So these are the different criteria for liver transplantation for early stage. Over time, the high volume centers, such as Milan in Barcelona, and UCSF in Japan, which is by Kudo, Professor Kudo, up to 7 criteria, in Toronto University, in Asan Medical Center, Hangzhou is in China, and then the French criteria is the Metro ticket. They follow the Metro ticket, where they use a very flexible limit, because they use the AFP and they use the response to treatment as their guide. All of these different guidelines our criteria are out there, but locally we use the Milan criteria because we're not high volume and we'd rather stay on the more conservative side. And this is really something that we need to achieve, because we still need to offer liver transplantation for patients, especially for multinodular and bilobar disease, which is not possible for liver resection, as long as they remain within the Milan criteria. And sometimes we can probably extend to UCSF, provided that the patient has a very, very good medical background. And of course, I don't need to reinforce or to highlight, but we need a multidisciplinary team approach to be able to achieve all of these. And not to mention that we also need a palliative and hospice care, especially towards child C and stage liver disease. So this is how it goes as a timeline for our HCC patients, from child A to child C, for all the different types of treatment where they can possibly belong, including palliative care. So in conclusion, hepatic resection for HCC beyond BCLC-A plays a big role, leading to long-term survival versus TACE and other treatment options. A liver transplant for early HCC remains to be an option. It needs to be explored. It needs to be perfected. And liver resection remains to be preferred when technically feasible, even in advanced stage, whenever it's clinically appropriate, and quality of life after liver resection is excellent, especially after minimally invasive liver surgery. And despite all of these, we must take into consideration the goal of our patients and the economical impact that it will bring to them. And beyond that, within the medical community, management of HCC is truly multidisciplinary. And therefore, we need to select our patients very, very well so that they can achieve the best outcome. Thank you very much.
Thank you so much, Dr. Catherine Te. May we award the Certificate of Appreciation to Dr. Catherine. She has made an indelible mark as a distinguished speaker at the Asian Cancer Institute Scientific Symposium, Hepatocellular Carcinoma, Screen Diagnosis Control, Cure, and Palliate. Our next speaker, may we welcome Dr. Jamie Marie Ramos Fernandez, a radiation oncologist who will present on the use of cyberknife and stereotactic radiation therapy in treating liver tumors. Dr. Jamie is a radiation oncologist here at Asian Hospital Medical Center, Asian Cancer Institute, General Santos Doctors Hospital, and the head of radiation oncology at Lorima Cancer Institute. Dr. Fernandez Ramos completed her medical degree at UERM Medical Center and radiation oncology residency at training at Jose Reyes Memorial Medical Hospital. She underwent her fellowship in image-guided brachytherapy at Gunma University Hospital, Japan, and stereotactic radiation therapy using cyberknife at Saitama Medical University International Medical Center, Japan. She is a recipient of the 2024 Young Researcher Encouraging Award by the Forum of Nuclear Cooperation in Asia and First Federation of Asian Organization in Radiation Oncology Leadership Development Program. So let's welcome Dr. Jamie Marie Fernandez Ramos.
Good afternoon, everyone. Thank you. I would like to thank Asian Hospital and Medical Center and also the Philippine Cancer Society for organizing this event on liver cancer and for giving us an opportunity to share about stereotactic body radiation treatment using cyberknife. So my lecture is entitled A New Hope for Liver Cancer using cyberknife SBRT. So just to give you, I'm sure it was previously mentioned, the cancer burden reported by GloboCan last 2020, and liver CA accounted for around 600,000 cases worldwide. And in the Philippines, it is the fourth most common in males, accounting to around 8,000 cases. So just to give you a preview of the radiation treatment centers in our country, as of 2025, we have around 60 cancer centers, and majority is located in the capital. And it's very sad to note that other regions in our country, don't even have a cancer facility, a radiation treatment facility. Others would just have one or two centers. For brachytherapy, so part and parcel of cancer treatment is also for the use of brachytherapy. So out of the 60 cancer centers, only half has brachytherapy, and this is used for our female patients with endometrial and cervical cancer. Now, to give you a preview, the cyberknife in the global setting, we have around 60 units in the United States. Cyberknife was developed in Stanford, and in Japan, where I did my fellowship, we have already 43 machines in our country. Almost each region has. And in the Philippines, we are very proud to share that finally we have the first and only in our country, and is available for all of our Filipino patients. So again, this is our, so we have more than 50 linear accelerator machines in the country. And again, the first cyberknife. So I'd like to share with you a video, especially those who joined us in the online platform. We would like to share a video that was prepared by our marketing. at least everyone has a preview of the CyberKnife. So what is CyberKnife exactly? This is a very unique and dedicated radiotherapy machine because it is used to deliver only stereotactic radiation treatment. And later on, I will explain more about stereotactic radiation treatment. And this is also a non-invasive treatment both for cancerous and non-cancerous tumors where radiation is indicated. So what is SBRT? So basically, it is stereotactic body radiation treatment. So we have the SRS, which is used in the brain. So for the body, so of course, we term it stereotactic body radiation therapy. And this is where we deliver high-dose radiation therapy to the tumor in very short courses of around 1 to 5 sessions only. And since we are giving very large doses of RT, so these doses are very ablative in nature. That's why another term for SBRT is stereotactic ablative radiotherapy, or SABR. So CyberKnife, as mentioned, was developed in Stanford back in 1988. And in the course of the years, it was improved in terms of delivery. And the current model, the S7 model, at 2020 has already the multi-leaf collimators, and as a result, treatment previously consists of around 1 hour, and now we can have treatment as short as 15 minutes. So these were the different models of CyberKnife. So on the right, that is the actual CyberKnife model that is installed in our hospital. So what are the key features of CyberKnife? So my professor in Japan specifically emphasized that CyberKnife is the only radiation machine that can perform real-time tumor tracking. So if I can explain, so our current machines, radiation machines, linear accelerators, or tomotherapy. So when a patient goes to the treatment room, we get to perform first a scan, either using an X-ray or a CT scan, and we try to check if the patient was positioned properly. Once we get to see that they are in the treatment position, that's the only time that we will treat the patient. Now, what's the difference with CyberKnife? So the patient is again positioned correctly, and then during treatment, the patient has continuous imaging. Every 30 seconds, every 40 seconds. If we are treating lesions in the brainstem, then we would image every 5 seconds. So as a result, the CyberKnife during treatment can follow the tumor. So there is imaging every intrafraction of the patient. So as a result, if we can image the tumor, we can deliver a very precise and accurate treatment to the tumor. So our margins are very minimal. We can put as small as 1 to 3 millimeters around the tumor. And as a result, there would be less radiation that is received by the normal tissues. There would be less damage and less side effects for our patients. This is also, again, a non-invasive treatment. And for the benefit of our patients, normally with conventional fractionation, our patients would undergo around 25 to 30 sessions, Monday to Friday, and that would be around 1 to 1.5 months every day. But with CyberKnife or stereotactic body radiation treatment, we can deliver in few treatment sessions. For example, for liver cancer, we can give it in 4 sessions, so that would be Monday to Thursday only. So this is another video, so you can have an idea of the actual treatment.
It's motion synchronized, personalized, real-time adaptive delivery of radiation anywhere in the body. Before treatment, an optical camera monitors the rise and fall of the patient's chest, while a series of X-ray images are taken to detect the tumor's position in relation to the respiratory pattern of the patient. This information is used to create a correlation model, a 3D map of the tumor's movement. The CyberKnife S7 system with Synchrony then uses the correlation model to predict the tumor's future position as the patient breathes naturally. During treatment, the CyberKnife S7 system continually verifies the tumor's location with X-ray images and monitors the patient's respiration, updating the correlation model as breathing or the tumor's position in relation to the chest wall changes. This allows treatment to be continuously delivered with sub-millimeter accuracy and precision, even if the patient's breathing pattern changes during treatment. The CyberKnife S7 system with Synchrony uses artificial intelligence to adapt and synchronize treatment delivery to the target's position in real time and paints a highly customized conformal radiation dose on the tumor, matching its shape while minimizing dose to nearby organs and other healthy tissue. Conventional radiation systems cannot synchronize treatment delivery with the targeted tumor's movement. These systems use uncomfortable restraints to limit motion, difficult and time-consuming breath-holding techniques, or periodically stop treatment when motion is observed. Even with these techniques, additional unwanted radiation spills into the healthy tissue, which means lower treatment doses, longer courses of treatment, and longer recovery periods may be required. The CyberKnife S7 system robotically positions the linear accelerator with 6 degrees of freedom to provide non-coplanar and non-isocentric treatment delivery from potentially thousands of angles. This allows the system to approach the target from the best possible unobstructed angles. The AI-driven robot repositions the treatment beam with sub-millimeter accuracy in real time during treatment, so that the beam is always predictively in sync with the tumor's position. This happens without human intervention, patient coaching, or pausing and stopping treatment delivery. Real-time adaptive treatments are delivered in as little as 16 minutes. And personalized, motion-synchronized, ultra-hypofractionated treatment plans are easy to create and can be optimized in as little as a minute. Together, this provides the patient throughput required to be successful in today's clinical environment. With
So I hope the video was you were able to see how the CyberKnife actually moves during a patient's treatment. And one of our speakers in the previous SBRT masterclass also compared using CyberKnife as an F1 car. As mentioned by Dr. Catherine Te, we need actually not just the expertise of the doctors, it takes a whole team to actually make this CyberKnife treatment work. So we need brilliant medical physicists, the radiation therapists who will actually position our patients and work on the machine, and also our certified nurses. So as a whole, we really value the different parts of our team, and some of them have already trained in abroad. Our medical physicists were sent already to Switzerland, our radiation therapists both in Switzerland and also in Japan. So this is the hospital in Japan, in Saitama International Medical Center. So that's my professor. They have a lot of machines actually, and they are treating more than 1,800 patients per year. So this is the actual CyberKnife in our center, and we were able to bring some of our radiation oncology doctors and staff in Saitama. And just to give you a preview, our university has been treating with CyberKnife since 2008, and they have already treated more than 3,500 patients, 6 to 7 patients a day, but just currently we've been treating 10 to 12 patients a day. 70% are treated with brain tumors. The other 30% are lung, liver, prostate patients, and we have already published articles about CyberKnife. So these are the clinical applications for CyberKnife, including liver CA. So we can treat during the primary and in the oligometastatic setting. So if we follow up patients after the primary treatment and we detect recurrence or oligometastasis, then we can still use CyberKnife. So again, oligometastasis is we classified it around a limited metastasis, 1 to 5 lesions in the body. And if we are able to deliver treatment, then we can still hope for cure for our patients. So I would like to focus more on radiation treatment for liver cancer. Of course, as Dr. Catherine Te mentioned, surgery is still the gold standard. So for liver cancer, radiation treatment is an option, and I would like to an option for patients who are non-surgical. And if I can show, so so this is the guidelines by the American Society of Radiation Oncology, and they advised radiation external beam radiation treatment for those patients who are not candidates for curative therapy like surgery or RFA. It can also be used as a consolidative therapy for those patients with incomplete response to liver-directed therapies, and also a salvage for those patients with local recurrence. So, as you can see from the algorithm, we always have, it is advised that the patients will undergo an MDT and check if the patient is a candidate, of course, for surgery or for a liver transplant. That is very, very important. Patient selection is important. And if the patients are not candidates for surgery, then that's the time we have options for our patients. And one of which is radiation treatment, whether in combination or alone with catheter-based therapies, as mentioned a while ago by Dr. Habito. So the first algorithm is with liver hepatocellular carcinoma without macrovascular invasion. On your right is the algorithm with macrovascular invasion. So in that setting, radiation can be used whether in the palliative setting or still with combination of catheter-based therapies. So again, for patients with liver confined HCC, EBRT is recommended using the dose escalated or the ultra or moderately hyperfractionated EBRT or stereotactic body radiation treatment. And we recommend that patients who will undergo this treatment would have daily image guidance. And I guess this is where the strength of CyberKnife will be beneficial, because as you saw, one of the features of CyberKnife is continuous imaging during treatment. And as a result, there would be less normal liver tissue that will be irradiated. So these are the doses that we use. So we have 40 to 60 gray in 3 to 5 sessions, or we can adjust depending on the classification of the patient. So again, with liver cancer, the tumor moves with respiration, and our patients may have already pre-existing diseases. They have comorbids. So perhaps a less invasive treatment is warranted, especially if they are not candidates, again, for curative surgery. So what are the comorbids? They may have poor liver reserve. Their tumor location and size perhaps is more than 3 cm or with close proximity to the diaphragm, gallbladder, or large vessel. Then CyberKnife can be a good option. So I mentioned a while ago, of course, SBRT delivers in 3 to 5 fractions. Most of the data available with SBRT are with child score A, though SBRT can still be used with child score B, but there would be some dose modifications and strict dose constraints for the liver. For child C, SBRT has not been established. So previously, radiation treatment was cautiously used because of the radiosensitivity of the liver tissue and the technical limitations in tumor delineation and radiation treatment delivery. But during the years, there was advances in imaging and radiation delivery. There was improved understanding of the liver tolerance. So as a result, there was increased use of SBRT for primary liver cancer over the last 2 decades. So again, we would like to compare some of the isodose lines that you can see during the plan. So during conventional fractionation below, we deliver 50 to 66 gray in 25 to 33 sessions. So that would last for around more than 1 month for the patient's treatment. But with SBRT, we are delivering high doses, 40 to 60 gray in 3 to 5 fractions. And as you can see, the isodose line is very confined to the liver tumor, and majority of the liver, normal liver, is spared. So this is a paper that reports on the outcomes after stereotactic body radiotherapy or RFA for hepatocellular carcinoma. So on this, we can notice that for our patients who underwent RFA and SBRT, the freedom from local progression at 1 year, as you can see, is very high. At 1 year and at 2 years, both more than 80%. And if we could note, for tumors that are more than 2 cm, they observed that there was a decrease in the freedom from local progression when it comes to RFA. So with SBRT, the size of the tumor doesn't affect the freedom from local progression using SBRT. So this was just published this year, 2025. In the previous years, we were awaiting the results of this study by Professor Dawson, a very well-known radiation oncologist in the field of liver SBRT from Princess Margaret. So this study compares SBRT versus SBRT with sorafenib, and they reported that the median overall survival, they noted improvement with the combined use of SBRT followed by sorafenib. And also there was improved progression-free survival also in the combination arm. So with this phase 3 randomized controlled trial, the use of SBRT prior to sorafenib was clinically important but not statistically significant for overall survival. And then this is the guide, we have guidelines from the International Stereotactic Radiosurgery Society. And as you can see also, they reported overall survival outcomes at 3 years and 5 years. And they noted improved local control of as high as more than 80% when we use SBRT for hepatocellular carcinoma. And in terms of tumor size, of course, patients with tumor sizes less than 3 cm are considered or candidates for SBRT. But with patients more than 3 cm, then we have to, of course, be careful with the normal dose constraints for our normal tissues. So just yesterday, I'm very proud to share with you a study from our university that was just published yesterday. This is stereotactic body radiotherapy using CyberKnife. This is a meta-analysis, and they reported around, I think, for 5 retrospective studies, 1 prospective study, including 697 patients. And they were able to show that the overall survival at 3 years was quite good at more than 50%, and local control of actually more than 80%. And as you can see, this is very consistent with the previous studies that we have shown a while ago. If we would have a review of the literature using CyberKnife for liver cancer, so I guess our results are comparable with the other studies with 2-year local control rate of 7 to 90%. And the side effects are equally important because it is less than 10%. So this is I would like to share an actual patient from Saitama University. So this is a SBRT for the liver with 1.5 cm, and we delivered 60 gray and 4 fractions and follow-up imaging at 2 years. So I guess we have very good local response, very consistent with the previous studies that we showed. So just to also, I want to add, apart from primary hepatocellular, we can also use SBRT for those patients that have developed liver metastasis. So this is also a recent publication by the International Stereotactic Radiosurgery Society for liver metastasis. And as you can see, the local control was surprisingly still high. Of course, at 1 year, still more than 80%, and at 3 years, 50 to 60%. So I guess that concludes our lecture. And with CyberKnife stereotactic body radiation treatment, we would like to share that hope does not disappoint. And I guess we have a new tool that we can use for our patients if they are not candidates, again, for the curative treatment like surgery or thermal ablation. So thank you very much for your kind attention.
Thank you, Doc Jamie, for that wonderful presentation on CyberKnife. We would like to award you the same certificate of appreciation. Signed this July 25th at Asian Hospital Medical Center. Our next speaker is Dr. Mary Ondini Manalo Igot. She is a board-certified medical oncologist practicing at Asian Hospital and Medical Center and De La Salle University Medical Center. She is also an assistant professor at De La Salle College of Medicine. Let's give it up to discuss systemic therapy, Dr. Mary Ondini Manalo Igot.
Okay, so the majority of patients diagnosed with hepatocellular carcinoma have advanced disease, and only a small percentage are actually eligible for potentially curative therapies. Furthermore, with a wide range of local-regional therapies available to treat patients with unresectable HCC confined to the liver, systemic therapy has been a treatment of last resort for those patients with very advanced disease. So good afternoon, everyone. So we've discussed already screening, diagnosis, all of the local regional treatments, and now we go to the systemic therapy for advanced hepatocellular carcinoma. Okay, so these are my disclosures. So some slides were lifted from our pharma partners as well. Okay, so this will be the outline of our discussion. Again, we'll be focusing on the BCLC algorithm, the evolution of systemic treatments for HCC, the 2025 NCCN and ESMO recommendations for advanced HCC, and we will be discussing how to choose the right systemic treatment for the right patient. Okay, so I think we've seen this for the 5th time already. And as a review, the BCLC algorithm is the most popular staging system, categorizing HCC into 5 clinical stages. So very early stage, intermediate stage, advanced stage, and terminal stage. So the BCLC system integrates tumor burden, liver function, performance status, and cancer-related outcomes. Sorry, it's not moving. So as you can see in this algorithm, the systemic treatment will encompass those patients categorized under BCLC-B, which is the intermediate stage, and BCLC-C, or the advanced stage. Okay, so treatment for unresectable HCC have evolved rapidly in the past years, and many phase 3 trials actually show promising results. So we'll not be discussing anymore all of these clinical trials in the interest of time. Okay, so we'll start with sorafenib. Okay, so the rationale of sorafenib is that the RAF kinase is overexpressed and activated in HCC. Sorafenib is actually a multikinase inhibitor that inhibits the RAF, MEK, ERK pathway, including the VEGFR and other kinases. So that's the rationale in giving. And the landmark trial that actually led to the approval of sorafenib for advanced HCC in 2008 is called the SHARP trial. So this is a randomized, multi-center, placebo-controlled clinical trial that enrolled a lot of patients who had not received any systemic therapy into sorafenib versus placebo. So the primary endpoints were overall survival, time to symptomatic progression, and the secondary endpoints was time to progression. So these were the outcomes. So the median overall survival in those given sorafenib was 10.7 months versus 7.9 months in placebo. And the time to radiologic progression was 5.5 months in sorafenib versus 2.8 months in placebo. Okay, so after 10 years, so after the release of sorafenib for HCC, now comes a new drug approved in 2018, and this is lenvatinib. Okay, lenvatinib is a multikinase inhibitor, much like sorafenib, but it has more receptors that it inhibits. So it inhibits VEGFR, FGFR, PDGFR, RET, and KIT. And by inhibiting the activity of all of these receptors, we also inhibit the downstream cascade of cell proliferation, survival, migration, and permeability. REFLECT is a multicenter phase 3 non-inferiority trial among patients with BCLC B and C. And these patients were randomized into receiving either lenvatinib versus sorafenib. The primary endpoint was overall survival, and the secondary endpoints were progression-free survival, response rates, and time to tumor progression. Okay, so in this study, the overall survival, the median overall survival for lenvatinib was 13.6 months versus sorafenib at 12.3 months, while the median progression-free survival was 7.4 months on lenvatinib versus 3.7 months on sorafenib. So this showed that lenvatinib was actually non-inferior to sorafenib in terms of efficacy, and this placed lenvatinib as one of the FDA-approved options for advanced HCC. So from TKIs or multikinase inhibitors, the treatment paradigm was then shifted into giving immunotherapy or immune checkpoint inhibitors. So the rationale behind combining an immune checkpoint inhibitor with an anti-VEGF antibody is that HCC is one of the tumors wherein it's so hypervascular, so there's a lot of expression of VEGF and PD-L1. So by blocking all of these, again, we inhibit the downstream cascade of all of the cell proliferation, mitosis, and growth of the cancer cells. IMbrave 150 is a phase 3 clinical trial done on patients with BCLC-B or C, Child-Pugh A, hepatocellular carcinoma. So these patients were randomized either into being given atezolizumab plus bevacizumab versus sorafenib. The primary endpoints were overall survival, PFS, and safety. So after a median follow-up of 38 months, the median overall survival for atezo-bev was 19.2 months versus 13.4 months with sorafenib. The primary endpoint of PFS, so again, it's superior. The PFS for bev-atezo was 6.9 months versus 4.3 months only on sorafenib. Okay, so a systematic review and meta-analysis of real-world data showed similar superior results. So this is a real-world study. So it says here that the median overall survival among real-world patients was 20.9 versus in IMbrave 150, it's 19.2 months. So pretty much the same. And the PFS actually for real-world patients was actually higher. It's 11.8 months, while in the clinical trial IMbrave 150, it's only 6.9 months. So it was able to replicate the findings in the clinical trial in the real-world setup. Elixir study is a real-world effectiveness and safety study of atezolizumab, bevacizumab among Japanese patients with unresectable HCC. So this is actually closer to home, Asian patients. The median overall survival was high at 26.1 months, and the median progression-free survival was 7.6 months. So again, this replicates the results from IMbrave 150. Okay, so the treatment paradigm again shifted. So from immunotherapy plus an anti-VEGF, we now go to dual immune checkpoint inhibition. So here comes Himalaya. So what's the rationale behind giving two immunotherapies in one? Okay, it has been studied that combining immunotherapies may further improve outcomes. So tremelimumab is an anti-CTLA-4 that blocks suppressive T-cell signaling in the lymph nodes, while durvalumab is an anti-PD-L1 that inhibits the suppressive PD-1, PD-L1 interaction in the tumor microenvironment. So when you block all of these, all of your T cells will now be able to kill all of the tumor cells in the body. Okay, so Himalaya was an open-label, multi-center, global, phase 3 study of patients with unresectable HCC. As compared with the initial study, the I Am Brave 150, I forgot to mention that EGD was required upon enrollment in the clinical trial to rule out pre-existing esophageal or gastric varices. In Himalaya, EGD was not required, but they basically enrolled the same kind of patients, BCLC B and C, with no prior systemic therapy, good functional capacity, child PUA. So in this clinical trial, there were actually 3 arms in the treatment. The first arm was the STRIDE regimen, wherein the patients were given tremelimumab plus durvalumab. The second arm was were the patients being given durvalumab alone, and the last arm was sorafenib, so the standard of care previously. The primary outcomes were overall survival, and the other secondary outcomes were progression-free survival, overall response rate, and duration of response as assessed by RECIST criteria. So in the STRIDE regimen, so that's tremelimumab plus durvalumab, these had superior overall survival at 16.4 months versus 3.8 months with sorafenib. And at 36 months, 30% were still on STRIDE regimen versus only 20.2% on sorafenib. Okay, durvalumab monotherapy. So this was the second arm of the treatment in Himalaya. This was also non-inferior to sorafenib in terms of overall survival. The median OS on durvalumab immunotherapy was 16.6 months versus 13.8 months on sorafenib alone. So there are a lot of clinical trials using immunotherapy already, but this slide just shows the comparison between I Am Brave and Himalaya. Majority of those patients enrolled in the trials were HCC from viral etiology, and shown here also are patients that were on atezo-bev, and they were in the clinical trial, or they were taking the medicines longer than those patients on tremelimumab and durvalumab. So in a way, it shows that more patients were tolerating atezolizumab and bevacizumab better than tremelimumab. On the last row, it says here that in the patients who had corticosteroid use, more patients were using corticosteroids for patients undergoing the Himalaya regimen versus the one in the I Am Brave 150. Okay, so the recent NCCN guidelines placed both atezolizumab and bevacizumab and tremelimumab durvalumab as both Category 1 preferred first-line systemic therapy agents. Other recommended regimens that are Category 1 and are available in the Philippines are durvalumab, lenvatinib, and sorafenib. Okay, this table shows a comparison of the different preferred systemic therapy agents available here in the Philippines. So just by eyeballing, atezolizumab and bevacizumab seems to be the best option in terms of overall survival and overall response rate. But of course, we're not allowed to make cross-trial comparisons, and we have to tailor our choices according to the goals of the patient, their comorbidities, as well as their financial capability to finance their treatment. Okay, so there are a lot of considerations in special HCC populations for optimal treatment outcomes. So we have to think about the medical, the physical host differences, comorbidities, competing risks, because a lot of these patients will have a bad liver to begin with, especially those patients with autoimmune diseases, CVD, risk of bleeding, and the disease etiology and the underlying biology differences. So this was initially presented at ASCO last year. So if you have a patient presenting with HCC, progressing on locoregional therapies or are not candidates for locoregional therapies, and this patient is a child PU class A, ECOG 021, you have to ask, is this patient a candidate for immunotherapy? So if yes, we have to ask ourselves, is this patient at high risk for gastrointestinal or esophageal bleeding? So if the patient has no increased risk of bleeding, then we give atezolizumab plus bevacizumab. According to them, that's the first or the preferred first-line treatment. But if the patient has a risk of gastrointestinal bleeding or bleeding from any other sources, then the preferred medicine or treatment will be tremelimumab plus durvalumab. Okay, if the patient will have an autoimmune disorder or is a transplant recipient, then the drug of choice will be lenvatinib or sorafenib. Okay, so this was released by ESMO just this year. So it basically highlights the same principles and decision making. So let's go through it to emphasize our point. So we have a patient with advanced HCC and we want to offer systemic treatment. So on the left side, if the patient is BCLC-D, so best supportive care, you may also opt to refer the patient to your radiation doctor to include SBRT for pain control. If the patient is BCLC-B or C, so that's the advanced stage, if the patient is suitable for immune checkpoint inhibitor therapy, then these are your options. So in here, it says atezolizumab plus bevacizumab. That's a category 1A recommendation. With magnitude of clinical benefit 5, and then durvalumab and tremelimumab, again, category 1A treatment, magnitude of clinical benefit 5. There are other 1A here, tislelizumab, but I don't think this is available in the country. The others were given a category 1B recommendation. So these are new immunotherapy. Nivo and EP is not yet available in the Philippines. Okay, so if these patients progress on your immune checkpoint inhibitor, then the TKIs will be the next best medicine to give them. So you have there lenvatinib, regorafenib, cabozantinib, sorafenib, and ramucirumab. So on the other hand, if your patient is not suitable for immune checkpoint inhibitor, then you offer your TKIs. You can give lenvatinib and sorafenib. The magnitude of clinical benefit here, it says it's a bit lower for sorafenib versus lenvatinib. So I think the reasonable first line would be lenvatinib if both are available. And then if they progress on your TKIs, then you can offer the other TKIs that you have not yet used for your patient. Okay, special populations. So what if your patient has an autoimmune disease? Autoimmune disorders actually range from those with very good prognosis like autoimmune hypothyroidism, which can easily be managed by hormone replacement. So this figure just shows us the spectrum from mild to severe risks when you have a patient with autoimmune disorder and you want to give immunotherapy. So in here, so for example, you have a patient with SLE and patient had a history of cerebritis. This patient maybe had myasthenia gravis. Maybe you would want to opt not to give your immunotherapy because it might push them to another neurologic syndrome, or your patient might have a myasthenic crisis. Of course, solid organ transplant patients, we don't give immunotherapy. Okay, so another special population will be patients with a higher risk of bleeding. Again, it's a spectrum. So on the mild spectrum, those with patients with CNS metastasis that can have a hemorrhagic conversion, those with esophageal varices, but of course, varices will vary in their severity. Or propensity to bleed, those patients who are thrombocytopenic to begin with, those on anticoagulation, those with severe esophageal varices, gastric varices. I think the only absolute contraindication will actually be a ruptured HCC. So the rest are relative contraindications, and I think you really need to get on board a cardiologist or hematologist if you have a patient who might present with a higher risk of bleeding, because even your TKIs can present with bleeding risks as well. Okay, so another population to consider will be patients with cardiovascular disease. So again, it is important to distinguish absolute from relative contraindications to angiogenic therapy, because we don't want to deprive a patient of a possible medicine which might help them in the long run. So hypertension, ischemic heart disease, arrhythmia. I think as long as all of these are controlled by your cardiologist, it is a relative contraindication, but active cerebral ischemia, active congestive heart failure, I don't think that we have we shouldn't be giving our anti-angiogenic therapy for these kinds of patients. So some future directions for immunotherapy, they are now in trials. So as a potential bridge to therapy, like while waiting for a liver donor, immunotherapy is also being explored to downstage tumors, and if they have a very good response, possibly curative conversion, since we have seen patients with exceptional responses to immunotherapy. So in summary, FDA-approved systemic treatments for advanced and unresectable hepatocellular carcinoma include multikinase inhibitors, so that's your sorafenib and lenvatinib, anti-VEGF, bevacizumab, and your immune checkpoint inhibitors. And combination immunotherapies are now a standard of care, leading to significant progress in patient care and treatment efficacy. And of course, we have to take into account certain factors that need to be evaluated prior to choosing the best treatment for your patient. So again, we have to get a very, very good medical history so that we won't be pushing a possible comorbidity of the patient. Thank you.
Thank you so much, Dr. Igot, for that wonderful discussion on immunotherapy. Now we present to you the same certificate signed today by Dr. Corazon Ngelangel, and we will be. Is it ready? The Zoom is ready. So we are on the last part of our discussion for today. So we are on the last part of our last speaker for today, rather. And she will be joining us via Zoom. Okay, so they're still preparing. Okay. But for the meantime, do you have questions? Maybe Dr. Pat, where is she? Ayan. Ay, okay. Please let's welcome Dr. Oh no, Dr. Marie Joanne Hoson. She's an intermediate past president of the Philippine Society of Hospice and Palliative Medicine and the national representative to the International Society of Geriatric Oncology. Currently, she serves as an active consultant at the Department of Occupational and Family Medicine here at Asian Hospital and Medical Center. She is also the head of palliative research at the Cancer Center of Makati Medical Center and the head of palliative unit care at Mary Mediatrix Medical Center Cancer Center. Please join me in welcoming the extraordinary advocate for dignified and compassionate care, Dr. Marie Joanne Hoson.
Thank you. So I'll share my slides. I'm the last speaker for today, but of course I'd like to congratulate everyone, a happy anniversary, and also congratulate those with the organizing of this event. So my role this afternoon is to discuss the supportive and integrated care for hepatocellular carcinoma, and my objectives are as follows. We have to actually define palliative hospice care. My colleague a while ago have focused more on the disease, right? And I will be focusing more on the personhood. So we'll look into various models of palliative care delivery, how our colleagues refer to our service, the different trajectory of illness in patients with cancer, especially HCC, and the importance of interdisciplinary involvement in palliative care, and how highlight how the all know healthcare professionals contribute to comprehensive patient support. And palliative care is everybody's business. So, like what I've said, my colleagues have focused on disease perspective, and now we look into personhood. So, we define palliative care uh, in terms of patients having a disease that's what you call this is incurably, that they are incurably ill, those that are elderly and dying. And palliative care is actually about lived experience of the illness and not just the biological disease. So the care is actually beyond medical interventions. The WHO has defined palliative care as quality of life and pertaining to the patients and their families with identification, impeccable assessment, and treatment of symptoms. Those are diagnosed with life threatening and life limiting illness, such as cancer. And we do it with a holistic approach because we don't look only on the physical, but also the social, emotional, cultural, and even spiritual aspects of care, and has to be supported in a interdisciplinary team. So previously, the old palliative care model is actually when the patient goes in their disease, and then the team would do a lot of interventions to prolongate their life. And then the referral goes to our service when patients are nearing death. Through time, there was evolution where life prolongation is shortened and there's more interventions in terms of symptom relief, and still our patients are being referred to us for hospice care and even after death. So that's what we call bereavement care. There's also a model where the step ladder of life prolongation, but again, the management is more on the symptom relief as the disease progress, and hospice care is still part of our services. So what we want to really advocate is the palliative care model for cancer patients, where palliative care can come alongside with all anti-cancer therapy, whether it be curative, life prolonging, or palliative in intent. And when the time comes that the prognosis is poor, for a 6 to 6 month prognosis, this is where a lot of symptom control, not only with physical, but psychosocial and emotional palliative care services really dwell on. And even after death, we deal with our patients' families, all right, not the patients, but their families, in terms of bereavement care and helping them cope through the loss. So the bow tie model of care is really actually defining this. It has evolved for so many years already, that overlaps the disease management and palliative care. Alongside with targeted therapy, chemotherapy, radiation therapy, palliative care comes in support to the to the curative, not to the curative and even palliative intent of care. But as the disease progresses, no, the trajectory of illness uh, towards the progression of the illness, more and more palliative interventions are being offered to our patients, such as the pain and symptom management. Apart from that, we also look into the quality of life of your patients, looking into their rehabilitation, right, their nutrition, and their psychosocial wellness. So um, by saying that, no, it's actually dealing with the quality of life, not only the patients and also their families. We deal with the symptoms. We look into their everyday, day-to-day tasks. We look into what makes them anxious, what makes them stressed, and we look into their mobility. And then, of course, relationships, friends, families are also important. So this is a holistic approach where the overall health of our patients are being addressed. This slide shows that from Scott Murray that a patient who will undergo um, a serious illness would have a lot of impact in terms of their social, psychological, even spiritual well-being. So as they go along their illness, there are parts of their journey where anxiety would set in when they have a physical decline and they get admitted to the hospital for certain procedures or certain treatments, and then they get separated from their families and friends. They get lonely. They feel a certain burden from their family being taken care of in the hospital or even at home. And some patients would worry about getting dementia, no, for our elderly patients when they have been admitted for quite some time and their cognitive function declines. Part of that would also have some loss of sense of control and also meaning and purpose. So these are the things where the palliative care team can help the multidisciplinary team in terms of addressing the other aspects of care, not only the physical, but also social, psychological, and spiritual. The physical aspects of care would be actually the addressing the medical concerns of our patients, but there's more to it, and there's that's the reason why um, cancer care is complicated, and it has to be a multidisciplinary approach where the other aspects of care is addressed by the palliative care team. So, in terms of referral, patients are referred to us when there are metastatic or locally advanced cancer progressing despite the systemic treatments like radiation, surgery, and chemotherapy. When their Carnopsy score is less than 50 or the ECOG score of our patient is more than 3. Patients who are diagnosed with brain nets, spinal cord compressions, or neoplastic meningitis, also patients with malignant hypercalcemia, and those who have progressive pleural, peritoneal, and pericardial effusions. These criteria are according to the CAPC, Center to Advance Palliative Care. NCCN also recommends the assessment by the oncologic team for patients whose screening confirms the presence of the following or more. And this is where the team also helps our patients and their families when their symptoms are uncontrolled, not only physical, but psychosocial and spiritual existential issues are being referred to the service. When there's moderate to severe distress related to cancer diagnosis, patients who are seriously comorbid with physical and psychiatric conditions. So, in our institution, the supportive and integrative services of Asian actually has a multidisciplinary team where we address um, personalized nutrition support. We look into specialized senior care, psycho-oncology, spiritual care, rehab, pain control, and palliative care and hospice care. So the patient and the family or the caregiver concerns about the course of illness, especially for a cancer patient, and decision making would have these things, no? A request for palliative care in the hospital or in the community. Patients who have complexities related to the social determinants of health, access to care when they are already at home, and patients who request for hastened death, we have to also do some form of counseling why there are existential issues and why they want to hasten their death. So for cancers associated with high morbidity and mortality because of the symptom burden. And then we help the team in terms of patients and families who have poor prognostic awareness. And of course, evidence of worsening prognosis is leaning towards more on symptom control. So NCCN also had additional indicators that include worsening prognosis, such as increasing in your ECOG score and Karnofsky's performance. Patients who are having cachexia and persistent hyperglycemia, those who have brain and cerebrospinal fluid mets and persistent delirium. Some of the emergencies that are referred to palliative care services would be the malignant bowel obstruction, those who have SVC syndrome, spinal cord compression, malignant effusions, and those patients who would need palliative stenting or venting gastrostomy. The ASCO and the American Academy of Hospice and Palliative Medicine also recommends that soon as a patient is diagnosed with advanced cancer, oncology practices should educate actually the patient and the family about the difference between palliation and hospice care, because there's always a misperception that when patients are referred to us, it's already the end of the line. No? But really, what our role is to improve quality of life and to address all those aspects of care, not only the physical but also psychosocial, emotional, and spiritual. And the guideline reported a strong consensus that referral to hospice care is indicated for patients with predicted survival of 3 months or less and a low score of ECOG, no, 3 to 4, that referrals be collaboratively agreed upon by the team and the patient and their families. So when patients are referred to us, we look into their functionality. Cancer patients typically have a good function at the start, and towards the death, we have a lot of interventions that need to be done because their functionality declines, physically, emotionally, because the symptom burden is very high at this time. And our role in the team is actually addressing all these. So, for a predictable course such as the lung, stomach, bowel, breast, brain, and cervix, we see a lot of decline in function towards death. So, the referral to a specialist type of palliative care should be available to your patient. And our role to help the multidisciplinary team is actually for the complex type of care. And this is a difference between an organ system failure where your patients are having already a less functionality compared to somebody who was recently diagnosed, and they have frequent admissions. And the dips in terms of function would be actually the admissions, the ICU admissions, the year admissions, and towards death, right? So it's a up and down, but never goes back to the same function. Okay. So for caring people with pre-organ failures, we see three stages. The first is when they're physically well, and the stage two would be the sentinel events, where active and supportive and palliative care will be of help to the team. So when they're admitted or after surgery or after ICU admission, these are areas where palliative care team can help um, the attendings to go back to their to try to go back to their normalcy and look into not only the physical but also the psychosocial. Again, the other support services would be your nutrition and rehabilitation. And the stage three, of course, would be the terminal care. And based from Petrillo et al., how does early palliative care address the needs of patients and their caregivers in the settings of cutting edge personalized cancer care? So, like I mentioned, managing physical symptoms of cancer actually helps the team in terms of addressing uh, the symptoms at an early stage. Whether we need to put these patients on a long-term opioid therapy or short-term to address their pains, but let them go back to their normalcy and improve their quality of life. Others would be actually managing the side effect of the treatment, where we do collaboration with the team in addressing the long-term effect of the toxicity of the um, therapy. Okay. Also, as I've mentioned, it's not only the patient but the family. So we are there to support the decisions of the patient and the family in terms of their preferences centered to their cancer directed therapy, whether they want to be hospitalized or they want the services to be done at home. So here in our institution, the SIS is actually a supportive program to bridge our patients who are in the hospital and wants to continue the care at home. And apart from that is the psycho-oncologic aspects of care is understanding the illness well, right? And discussing with the patient and their families regarding potential outcomes, including exceptional responses. And lastly is actually supporting, coping with the uncertainty and navigating changes. So when our patients um, are having difficulty going back to their previous functionality or even the ability to go back to their work, so they need some form of guidance and counseling with our team to be able to cope with with their illness. Okay. So with that, I'd like to stress that it's palliative care is everybody's business. No, I've been mentioning that the whole team, the family members, even the community will have a big role in terms of improving quality of life of our patients. And who constitutes everybody? I'd like to share this slide video with you. I hope you were able to hear the video. So I'm down to my last two slides. So the pros would be palliative care is a specialized medical care focused on providing relief from symptoms and stress of serious illness like cancer, regardless of diagnosis or stage of disease. So again, palliative care can be given in addition to cancer treatment or to those with no curative treatment options. We aim to improve the quality of life for both the patient and the families. And palliative care addresses many of the challenges that can affect quality of life of a cancer diagnosis, including emotional changes, anxiety and depression, the physical burden, no, adverse effects of the disease and its treatments, such as pain, the most common, and others would be nausea, vomiting, fatigue, difficulty of sleeping, and loss of appetite. So others would be practical challenges, such as navigating the healthcare system. So in our team, we have the patient navigator so that our patients be directed to the appropriate care and services in the hospital or even in the community. And also decision-making challenges when patients and families are unaware of their options. Also, the spiritual and existential issues. We are also helping the multidisciplinary team in addressing that. And the early integration of palliative care in the cancer continuum is recommended as shown with the evidences. With this, I'd like to share my last slide. Oops, sorry. again to add life to their days and not days to their lives. To cure sometimes, to relieve often, to comfort always. This is the work we do. Thank you for listening and good afternoon.
Thank you, Dr. Johnson, for presenting. Now it's the point of the program where we are opening out a panel. May I please ask the remaining speakers, and of course, Dr. Pat, to facilitate the question and answer.
Thank you very much, Dr. Hoson. Okay, so in the interest of time, we will be entertaining 1 to 2 questions from the audience. Does anyone have questions?
This is a question for Dr. Ate. So, ma'am, I'm a medical oncologist, and sometimes we see a lot of patients na sana na-ooperahan but they cannot be operated on because of baka yung tumor location, it's very near a vein or a blood vessel. In your practice, do you see a lot of medical oncologists giving parang neoadjuvant treatment so that the tumor can be converted to a resectable one? So if yes, ano po yung mga medicines which you think are the ones giving the best responses?
Okay. Thank you for that question. First and foremost, the decision to operate does not reside on the oncologist. It resides on the surgeon. And even if there will be a full room of surgeons here, one surgeon's decision will differ from the other. And especially when we talk about the vascular proximity, in liver, any tumor will be just next to a vein or to an artery because the liver is so vascular. So it really is not about taking the vein, because we're very liberal in that, but looking at what we can preserve and what we can reconstruct. And that makes the difference in terms of other types of tumors, perhaps, that undergoes surgery. So that's the important, I think that's the importance of knowing the anatomy and having a very meticulous quality preoperative scan and planning, so that during the multidisciplinary conference, we can all look at it, see it, and decide on what is the best for these patients. The most common indication for neoadjuvant or downstaging for our patients is because of the lack of liver volume, not the proximity of the tumor to the veins or to the vessels. Because even with the portal vein invasion, with IVC invasion, we still take the veins anyway. I think that's the difference between a transplant surgeon, a liver transplant surgeon, and the general surgeon, is because we are ready to resect the veins or the arteries and reconstruct, as what we do in liver transplant. So I think that is the reason why the basis in terms of resectability does not reside on the size or the proximity alone, but really in being able to leave at least a good inflow and an outflow for the segments that will remain in the patient. And try to find, parang ano lang kami, plumber. Hahanap ka lang ng saan mo pwedeng ipagkakakabit sila. And to allow the remaining liver to be viable and prevent ischemia and congestion. Because it's not just simply the ischemia, but also the congestion. So yung outflow, the hepatic vein, needs to be open, needs to be there. Without an outflow, the liver congests, we still end up with liver failure, even if you have a good supply. Yeah. So those patients that undergo neoadjuvant are the ones with usually large tumors with very small remnant. So in the hope of downsizing, making the size smaller, and such that we will have a bigger volume left behind, then we can go and resect them. We do have a fair bit of experience on that, where patients undergo systemic treatment with atezolizumab or some with lenvatinib, but mostly a combination. Like I showed earlier a case, the one with SIRT. Usually these are the ones that have better chances because the SIRT gives us the opportunity for the contralateral side to hypertrophy. In systemic treatment, sometimes they just shrink in size, but we don't see a hypertrophy of the contralateral side. So we still end up with stage resection. But at least we give them the opportunity to give ourselves the opportunity to wait and see. It's a test of time, and see if there's any metastasis elsewhere, or if the liver withstands the insult by the systemic treatment. Then we know that the liver relatively has a good function, and we can proceed and do the surgery. The decision making in deciding whether it's resectable or not does not simply reside on the proximity to a vessel, but there's so many other factors that we consider.
Thank you, ma'am.
More questions? Okay, last question, no? For Roy. So Dr. mentioned CERT, no? We have a lot more evidence data for TACE in the HCC space, no? Who are the patients who generally would choose CERT over TACE? Particularly in HCC.
Meaning which patients would be suited better
Yes.
for TACE? Okay.
That
So
you will choose CERT over TACE.
for medium-sized tumors, the blunt answer is if the patient can afford CERT, it's usually worth considering. Ano yan? But for huge tumors, even though Dr. Te has an example, in the international community, usually you don't jump to CERT for a gigantic tumor. And we do have a lot of that locally. The reason is, if you saw that snippet of a photo dun sa CERT versus TACE, you do have just one vial with CERT. No? We have a delivery box that there's a contraption that we use. And realistically, you're just trying to infuse basically one vial of material. And imagine if you have I don't know, a basketball size, as the slide says, no, basketball size tumor. Hindi mo talaga makukot yun. It's like asking you to paint a building with one can of paint. You just simply can't. Kulang ang isang can. Now the proverbial can is bigger when we have doxorubicin with lipiodol. So that's where the balance shifts a little bit toward conventional TACE. But the answer is the biggest drawback to CERT is really the cost, because the selling point, of course, this is partly something that the company is proud of from marketing standpoint, is that there's the toxicity profile is lower. The patients are up and about a little bit faster, and the outcomes are comparable.
Since we have the radiation oncologists here with us, there are so many studies that have shown the efficacy of SBRT on portal vein thrombus, on large tumors that are unresectable, and we would be able to downstage them and proceed with transplantation even. So in our setting, would it be a possibility, for example, Roy doesn't want to give the SIRT, and SBRT can be an option, right? Yeah. So I'd like to know what's the indication, how do we decide on that, and how do we go about it?
Doctora, thank you for that question. Actually, in one of the studies I presented a while ago, I think with the guidelines of the ASTRO, yeah, Doc, on that algorithm on the left side, there's that part. There are some studies, limited studies, where SBRT can be used as a bridge towards liver transplant. There are studies, but of course, these are limited, as you mentioned, and the results are still, it's possible. It's possible. It's still an option, but at least we are aware that it can be done. Yeah, but because some patients are really candidates for a transplant, but of course when you catch them, they are not yet candidates. But if you get to downsize using SBRT, and then they can, and I think some are still awaiting for their donors. So that's why those are one of the I think indications where those patients use SBRT. It's to buy time before their transplant. Yes.
Partly also to control the tumor, to control the disease. And we have very limited data on this, but very high number of patients done in Medanta in India. They have very, very good outcomes. And subsequently, patient can undergo surgery. And also in Hong Kong, where RT can be the SBRT with or without systemic treatment, and subsequently resection, stage resection, or even liver transplantation were undertaken by these patients. So I think it really boils down on how we would be able to come up with our own experience, protocol, and go beyond the learning curve. Because even if we look at the different like BCLC criteria and all the different guidelines, it would say HCC less than 3 centimeters, ablation is the best. Very good overall survival, the same disease-free survival. But in reality, if you look at our own data, it doesn't hold true. RFA, MWA in our country sucks. The outcome is poor. No, that's true. The people who are doing it claim that it has the same outcome, but it doesn't in our setting because we have not reached that beyond that learning curve. While in other countries, they can say that the overall survival is the same, the disease-free survival is the same between surgery and and ablation. I agree, but that's because this is a high-volume center. But in our case, our patients even end up with abscess, with fistula. So it doesn't really change the picture, and that's why I am very, very hesitant to send our patients for ablation. We started sending them before, giving them a chance, but then patient come up with fistula, with abscess, with pneumonitis. Sabi ko, ayoko na. Operahan ko na lang.
Thank you very much to our speakers. Tonight we've had today we have a very fruitful afternoon. We have discussed high yield lectures from our esteemed speakers for the whole continuum of hepatocellular carcinoma, from screening to diagnosis to treatment and palliative care. I think that hepatocellular carcinoma is one of the hardest cancers to deal with. And when you see guidelines alluding to individualizing systemic treatment, dependence on the quality and the expertise of the centers, you know that's a difficult cancer to treat. And that's what we exactly saw from the lectures that we had today. We also saw in the lectures how, with the experience of our speakers, we are able to treat more of the patients. We are able to do more treatment in terms of our local regional approaches. We are able to deal with bigger tumors. More tumors are traditional problems on portal vein thrombosis, difficult locations. We've seen from our different speakers how they deal with all of these, and we are able to maximize our local regional treatments. We've also seen how systemic treatment has complemented this, and we also saw in the course of the discussions that one modality improves or also makes issues with other modalities. And then hence, this highlights to us how dealing with hepatocellular carcinoma boils down to the theme of 1, proper patient selection, number 2, a very strong MDT. A very strong MDT, as mentioned by Dr. Te, where individual members strive to upskill themselves, and the team as a whole really coordinate the sequencing of all of these modalities. And of course, as is the general theme of this afternoon, the importance of institutional strength. So they've talked about guidelines and how adapting these guidelines locally is very important, especially in the context of hepatocellular carcinoma, where Western guidelines do not necessarily apply to us, where local experience really will add up and even further refine our approaches. So with this, we hope that we made your time today here worthwhile, and we invite you to our 10th ACI anniversary. I think you are hearing the sound from the ACI. So we have wine, cheese, and food. We hope you could come with us. Thank you.
Alright, so ni-spoil na tayo ni Dr. Pato that yes, we have a 10th year celebration downstairs. But before that, may I please request everybody who stayed here, play it to kindly go in front so that we can take a group photo together to celebrate. And again, we want to thank you for your time and your patience. I know you guys are very busy, especially Dr. Cora. She stayed the whole afternoon. Dr. Te, who really tried her best coming from Shangri-La. Oo. Ayan. Doc Habito, step forward tayo ng konti. Ayan. And in behalf of Asian Hospital and Medical Center and the Asian Cancer Institute, we thank you for being part of this important symposium. Let's continue to work together towards better screening, diagnosis, treatment, and care for patients with liver cancer. Have a safe day ahead. We want to sincerely thank our sponsors as well, the people who made this possible: Asian Cancer Institute, the Department of Social Welfare and Development, medical experts and our guest speakers, Roche Philippines, of course, Asian Hospital Events, Marketing, and Clinical Teams. Thank you so much. You have a good afternoon.